And as you can see, the topic of my lecture is Epidemiology of Cholestatic Liver Disease, and this is kind of introduction for the next two lectures that will focus on the treatment of cholestatic liver diseases. So first of all, I mean, cholestatic liver diseases, it's a pretty wide term encompassing a lot of diseases with the underlying mechanism of cholestasis-induced liver injury. However, when thinking about cholestatic liver diseases in hepatology, then we usually think about primary biliary cholangitis and primary sclerosing cholangitis, and exactly these two topics would be focus of my presentation today. Okay, so I will start with statement that PSC and PBC are rare disease, and according to definition by European Commission, rare diseases are those affecting less than 5 patients per 10,000 inhabitants, meaning less than 50 per 100,000 inhabitants. And being a rare disease is not the only problem when trying to understand the epidemiology of cholestatic liver disease, but also there are many methodological issues. For example, we still lack exact ICD-10 code in ICD classification. So there are problems when studying the epidemiology of this disease. Nevertheless, there are many studies published on the epidemiology of cholestatic liver disease, and this one is a very informative one. This study was published in 2012 in form of a systematic review. And what we have learned from this systematic review is that really PBC and PSC are indeed rare diseases. They are distributed differentially across the globe, and that the most data have been retrieved from the Western population, and that we lack really the knowledge about the epidemiology of cholestatic liver disease in the eastern part of the world. And this slide here is the graphical summary of the main results of this systematic review. And here on the left-hand side of this slide, you can see the incidence rates of the cholestatic liver diseases, whereas on the right-hand side, you can see the prevalence of these two diseases, with PSC depicted in the dark blue bars. What is clear on the first side is that both incidence and prevalence rates of PBC are higher than PSC. And the second thing is that there is huge variability in the reported rates of incidence and prevalence in these two diseases. And again, most of the studies were studies coming from the Western world. And this study pointed to the existence of certain geoepidemiological declining gradient in terms that there is decreasing frequency in both PBC and PSC starting from the northwestern to the southeastern part of the globe. More precisely, the reported incidence rates of PSC were ranging from 0 to 1.3 per 100,000 inhabitants per year, with corresponding figures for PBC 0.33 to 5.8. The prevalence rates for PSC ranged from 0 to 16.2 per 100,000 inhabitants, with corresponding data for PBC 1.9 to 40 per 100,000 inhabitants. As you may notice here under PSC, there are 2 zeros reported, and the zero prevalence and incidence of PSC was reported in Alaska. So after this general overview, I would like to focus more deeper in the epidemiology of PBC. And PBC, although the prevalence of PBC, point prevalence in different areas of PBC has been reported to be very different, still analyzing the temporal trends in PBC prevalence, almost all authors came to the same conclusion, and that is that there is an increase in prevalence of PBC with time, with almost parallel curves. And this, to some extent, should be resulting from the increase in PBC incidence, which especially holds true for women population, whereas the time curves of PBC incidence for males are stagnant one. As I said, we are lacking data from the East. However, in a couple of last years, several studies were published shedding more light on this issue in the eastern part of the world. And here are the results of the large-scale epidemiological study on the Chinese population with PBC coming from Hong Kong. And in this study, the authors analyzed the public healthcare database in Hong Kong over the span of 15 years, and they managed to identify more than 1,000 PBC patients, and they reported increase in the annual incidence rates from 6.7 to 8.1 per million person years, with prevalence rates increase from 31 to 82 per million. So again, these figures are lower than those reported in the western part of the world, but also rising with rising incidence and prevalence. The 5 and 10-year mortality overall survival rates were 81 and 78%, and 5 and 10 years mortality probability of hepatocellular carcinoma were 1.5 and 2.8% respectively. The authors of this study also managed to identify the factors associated with the different survival rates of PBC patients. And according to multivariate analysis, male sex, higher age, older age, and cirrhosis at the baseline were factors associated with the lower survival, whereas the treatment with ursodeoxycholic acid conferred protection. So these patients survived longer. Now coming back to this area, to Central European region, there are some data, although we still miss data from all the countries. However, there are some data coming from Slovakia and Czech Republic, and this table was courtesy provided by Professor Skladany to me, and I adapted this table with some data from Croatia. According to these data, the prevalence of PBC in Slovakia is 14.1 per 100,000 inhabitants, with corresponding figures in the Czech Republic 11.5, and the figures for Croatia are 8.75 per 100,000 in population. However, when talking about Croatia, these figures are not representing the entire Croatian population. They represent only the catchment area of my hospital, which covers about 320,000 inhabitants on the northwestern part of the Croatia, and my hospital is located on the eastern part of the Zagreb. So, although not representative for whole Croatia, still these data are showing, are confirming this declining gradient of the epidemiology of the frequency of these two of primary biliary cholangitis from the north to south. So when thinking about, when thinking about these data on different epidemiology and different distribution, rising figures and different unequal distribution of PBC worldwide, we should think about factors that might contribute to these figures. And of course, first of all, we may say that we have improvement, we have been facing improvement in diagnostic tools for PBC. Starting from 1965, anti-mitochondrial antibodies has been discovered, and since these antibodies has become indispensable part of a diagnostic algorithm for cholestatic liver disease, then there is increasing awareness of the disease among the healthcare professionals. Then introduction of computer resulted into digitalized patient registration, making it easier to assess the patient data and to analyze this data. Then there is improved survival upon ursodeoxycholic acid treatment, furtherly adding to the increased prevalence of PBC, although not all authors would agree on this issue based on some studies. And with respect to the unequal worldwide distribution, there is certainly influence of some environmental factors and some toxic compounds and some infections, especially urinary tract infections, have been accused to be connected with the development, with the pathogenesis and development of PBC, and also genetic background, because it's usually observed that there is a clustering of PBC patients within the families with an affected member. In terms of survival, patients with PBC have diminished survival as compared to general population. However, when analyzing asymptomatic patients, so during the first 11 years of disease duration, survival is not really different compared to general population. However, starting from the 11th year on, these survival curves goes into a very divergent direction, and the survival of PBC patients is diminished. As chronic liver disease, PBC is also connected with the increased risk of developing hepatocellular cancer. And according to data from the global PBC study, cumulative incidence of HCC in PBC patients have been calculated to be about 10% after 20 years of disease duration. Now I would like to switch to epidemiology of PSC, and PSC is even more rare disease than PBC, and this meta-analysis came to conclusion that the pooled incidence rates of primary sclerosing cholangitis is around 1 per 100,000 person years, and that the PSC is more frequently diagnosed in males than females with a ratio of 1.7. Usually at the age of 41, and most authors reported on overall increase in the incidence of PSC with time. Then going back to Bundstra study that was published 1 year after this study. So as I said, Bundstra study also included mostly data from the Western world. However, there is a study from Singapore, one study coming from the Southern Europe, and one study from Alaska, here reporting significantly lower figures in terms of incidence and prevalence of PSC as compared to the Western population. And please note that majority of patients were males, and about 60 to 70% of patients with PSC had concomitant inflammatory bowel disease, most usually ulcerative colitis. A year later, study from Japan came, giving us some insights into epidemiology of PSC in the eastern part of the world. And according to this study, the prevalence of PSC in Japan was calculated to be 0.95 per 100,000 inhabitants. The authors of this study failed to calculate incidence rates. However, when looking at the reports from two national surveys performed in Japan in 1997 and 2003, the number of PSC patients nearly doubled. Speaking clearly about the epidemiological trends which are similar in Japan as in the rest of the world. And the authors of this study also revealed two unique features of the Japanese PSC population. First, that there are two peaks in the age distribution at diagnosis. First one starting at 35 to 40 years, and the second one at 65 to 70 years. And fewer presences of IBD occurring in only 34% of patients, so half the number of patients as reported in the Western studies. Again, thinking about these very unequal reports on the incidence, prevalence, and worldwide distribution of PSC, thinking about the factors that could be responsible for such figures. First, we think about the improvement. We should notice that there have been improvement in diagnostic tools for diagnosing PSC, starting with the introduction of ERCP in 1970, then introduction and development of MRCP in 1991, again, computers and digitalized patient registration. Then, of course, PSC is accompanied with IBD, especially ulcerative colitis, and then, as we know, the the epidemiology of IBD is very variable around the world, and therefore it is logical to expect the variable distribution of PSC around the world as well. However, when speaking about influence of genetic factors, leading authorities in the area today believe that genetic is responsible for only 10%, for less than 10% of the disease liability for PSC, whereas more than 50% should be prescribed to unexplained, some unexplained environmental factors. In terms of survival and the prognosis of patients with primary sclerosing cholangitis, these patients obviously had worse prognosis as compared to general population. In fact, there is 4 times increased risk of mortality, with the most frequent causes of that malignant diseases, especially cholangiocarcinoma and liver failure. And the malignant diseases account for about 40% of the causes of death. So the authors of this study, coming from Netherlands, calculated cumulative risk of cholangiocarcinoma to be 6% after 10 years of disease duration and 20% after 30 years of disease duration. Of course, as we already mentioned, patients with PSC usually have ulcerative colitis, and they have increased risk for developing colorectal cancer, and this risk is 10 times increased as compared to ulcerative colitis patients without PSC. Also, colorectal cancer develops in younger age, so 39 versus 59 years of age. In terms of survival of PSC patients, in the mean survival of these patients, or time to death, these patients have diminished survival compared to general population. However, what became evident from the epidemiological study, there are two different populations in terms of duration of survival, so depending on the clinical background from which you analyze PSC patients. So if you analyze PSC patients from the transplant centers, then their median survival is 13.2 years. And if you analyze the patients from population-based cohort, then their survival is 21.3 years, which is statistically significantly different. And it is really logical and easy to understand these figures, because majority of patients which are followed up in transplant centers are patients with more severe, more advanced liver disease, more advanced PSC. Recently, a large multicentric study reported on the epidemiology of PSC, in which 37 centers from Europe, from North America, and Australia have been included, and they identified more than 7,000 PSC patients, mostly men, with 90% of patients having classical or large duct disease, and 70% of patients with IBD. So what they reported is that the 36.7 patients either died or had to undergo liver transplantation of this cohort, with the median time to that point, to that event, of 14.5 years, so very similar to previously mentioned data from Bundstra study. And 10% of the entire cohort of patients developed hepatopancreatobiliary malignancy, mostly cholangiocarcinoma, that accounted for 82.4% of cancers. The authors of this study also tried to identify the factors, demographic factors and the disease phenotype factors that might be connected to different survival and different course of primary sclerosing cholangitis. And according to this analysis, cumulative liver transplant-free survival was significantly better in patients in whom PSC was diagnosed at younger age as compared to patients in whom it was diagnosed at older age. Whereas in terms of cumulative incidence of hepatopancreatobiliary malignancy, patients diagnosed at younger age had better figures, whereas patients with diagnosed at older age had significantly higher cumulative incidence of hepatopancreatobiliary malignancy. Also, worse outcome was reported for males versus females, for ulcerative colitis versus Crohn's disease, and large duct versus small duct primary sclerosing cholangitis. Finally, these patients with cholestatic liver disease come to the point where they need liver transplantation, and these are figures from Croatia. So in Croatia, we transplant about 150 patients per year, and the most recent figures for 2016 and 2017 are in terms of PBC and PSC, so we transplant about 6% of the entire cohort of transplanted patients for these two conditions. Once transplanted, these patients usually, not usually, but these patients face recurrence of the disease. And according to this systematic review published in 2006, the recurrence rates for PBC is 11% in transplanted liver, and for PSC 11% in transplanted liver, although there are some studies reported which reported significantly higher figures. For example, one reporting for PSC almost 59% recurrence rate. So, dear Chairman, ladies and gentlemen, I would like to conclude with this. So, PBC and PSC are rare disease with unequal geographic distribution, with temporal trends showing increase in incidence and prevalence rates of these two conditions. We still lack the knowledge of the etiopathogenesis, and therefore the studies on epidemiology are important. And of course, based on this survival data, it's clear that we need new therapeutic options, although some options are already on site. And I would like to invite you to another liver meeting called Adriatic Liver Forum, traditional regional meeting occurring each year in Zagreb in March. So the next meeting would be on 2nd March 2019, and you are all very welcome to participate. And this is the website where you can find all the important information. Thank you very much.
Thank you, Professor Grgurevic, for a wonderful presentation, a very comprehensive review. And if I may have a question, can you comment a little bit on the growing incidence of PBC and PSC from the point of view of the microbiome concept? There is quite an elegant hygienic theory explaining growth of autoimmune and allergic diseases in the recent time. From the point of view of decreased rate of infection of neonates and young babies by H. pylori, by other bacteria. What do you think, what may be the role of decreased contamination of young children in so-called of immunological window time, the first year of life, in growing incidence of autoimmune diseases, including the cholestatic diseases?
So I'm sorry, I didn't understand the last part of the question. So what do I think?
The role of microbiome changes, global changes of microbiome in the population in growing incidence of autoimmune liver diseases.
So this is very interesting hypothesis, and I believe there are a lot of data supporting importance of microbiome in different liver diseases, as we were noticed in the previous session. So microbiome is obviously very important here in development of these two diseases, and there are also studies showing that there is influence of microbiome and also of leaky gut to development of these two conditions, especially some connections with primary sclerosing cholangitis. So I think it is important, but it's obvious that we are still missing a link and very precise association between the inception of the pathogenetic state and the final disease phenotype. So a lot of things are
definitely. Thank you. Thank you. The report is open for discussion. Any questions from the floor?
Sorry?
Thank you, Marek Hartlet from Poland. My two questions regard capturing of data for epidemiological studies. Prevalence of PBC must be based on prevalence of antimitochondrial antibodies. Do you know any studies conducted on large population of potentially healthy persons on screening studies on prevalence of antimitochondrial antibodies. Could you comment specificity of antimitochondrial antibodies to PBC? Because you observe these antibodies in connective tissue diseases as well. And second question, it is that ulcerative, we much better know the epidemiology of ulcerative colitis. And we know that 5% of patients with ulcerative colitis are affected with PSC. So this is a different approach to knowing the epidemiology of PSC. And if there is large discrepancy between such approach to studying epidemiology and cholangiographic images, positive diagnosis, mostly coming from reference centers.
Thank you for your question. So with respect to antimitochondrial antibodies, so there are some figures showing the prevalence in certain population, and there are specific for primary biliary cholangitis. However, there are also some patients diagnosed with positive antimitochondrial antibodies without any signs of liver disease. And I think I'm not completely sure about the numbers, but I think about 10 to 15% of these patients finally would develop later on primary biliary cholangitis. So and certainly these antibodies occur more commonly in patients with other autoimmune disease. So for some patients, these antibodies come as the part of more, let's say, autoimmune diathesis, and maybe as only one in the number of antibodies. But for certain patients, these positive antibodies without liver disease at the beginning, these patients will develop liver disease in a fraction 10 to 15%. And for the other question, I'm not sure the point of the other question regarding the epidemiology of PSC and ulcerative colitis.
Can we get knowledge on PSC epidemiology just by knowing the prevalence of ulcerative colitis?
No, because most patients with PSC have ulcerative colitis, but not most patients with ulcerative colitis develop PSC. So I don't think that this is although there are some studies which when they analyzed the epidemiology of PSC, then they took the data from liver transplant centers, and they also took the data from IBD clinics. Because certainly if you analyze patients with PSC, you have possibility to identify more patients with PSC. But as you know, the fraction of patients with ulcerative colitis who will develop PSC is about 6–7%. And vice versa, in patients with PSC, you will have 70% of patients with ulcerative colitis. I don't know if this is a good answer to your question.
Okay, we have to finish this interesting discussion. Thank you, Ivica.